Well, I thought today we would just spend time. Usually I talk about the heart and I explain a lot of things about heart health, and cholesterol is one little part of that. But I thought we would just spend time talking about cholesterol because it's been in the news a lot lately. And you know, when you look at it in the news, it almost takes on a religious significance. The people that argue for cholesterol are so passionate about it. The people who think cholesterol is a bunch of bunk are equally passionate. If you look at England, they have two major medical journals there. The BMJ is one and the Lancet's the other. And the editorial staff of one of them is pro-cholesterol and the other is anti-cholesterol. And they just go at it all the time. And there's no compromise to them. We have a guy in this country, David Nissen, who's a big cardiologist, I think at Cleveland Clinic. And he writes a lot about cholesterol, and he's been really pushing it lately and saying that people are not going on cholesterol medicines enough, that the reason they're not going on is because the internet is spreading lies about the negative effects of it, and people are reading the internet too much. He's written a bunch of articles about this recently. And it's, again, he has this idea, he's one of the advocates of cholesterol in the water. You know, there should be cholesterol medicine in the water. We all should be on it. And this is the greatest thing since sliced bread. So I just wanted to talk about kind of how we got to this point, why cholesterol has taken on this mythic religious significance, when it should be treated, when it should be measured, how we should treat it. And you know, ultimately there's no right answer, as with everything. It's a decision that each person has to make. But I think the information people are making the decision based on is inaccurate. And that's the problem. Everyone just gets this information and doesn't know what the truth is. And the truth is out there. We kind of know what it is. It's just that people view numbers differently. So, how did cholesterol get to be this big thing that we talk about? Well, you can look all the way back, it's in the, I think, 1950s, 1960s. Two things happened back then. Number one, there was a guy who wrote a study called the 7-Country Study. And it was about cholesterol, and it showed that in nations that had the highest consumption of cholesterol, fatty food, and in nations that were more industrialized, the rate of heart attacks were higher. So he made a correlation between eating fatty foods / high cholesterol and heart attacks. And that became a gold standard that was followed by other subsequent studies. Looking back on that study, there were major flaws in how it was done. The most blatant of which was that he studied about 14 countries and excluded the ones that didn't go along with his theory. So, and that's the way research was done and is still done to this day. You do research until it agrees with your theory, and then you publish that. Most medical research that's done is never published because it does not reach the conclusions that the authors wanted to reach. The second thing that was being done back then was that the sugar industry, which was quite powerful, and I don't know if it still is, was actually paying off academics to publish articles saying cholesterol was the problem. And therefore, sugar is not the problem. And we have evidence of that now. That just came out fairly recently, that there are a group of people from Harvard who were paid off to do these studies. So we know there was this push back then to get out the idea that cholesterol is important. And we all remember the time when we were told we should not be eating cholesterol. Don't eat eggs, don't eat shellfish. We all remember the time when, and it's still true to some extent, where people were pushing low-fat products. Low-fat ice cream, low-fat cookies. And that's still to the extent, but if you have a low-fat product, of course, you put in sugar. More sugar, less fat. So this myth developed of the importance of cholesterol. And in two ways. Number one, that we have to measure it. And number two, we have to treat it if it's high. And that became kind of the dogma. And there are very few people who question that to this day. And like I said, to the people who believe in it even now, they believe in it religiously. You don't question them about that. I've seen people turn red in the face when people do. So what is cholesterol? First of all, cholesterol is produced by our body. We make cholesterol. But we make lots of types of cholesterol. People have heard of LDL and HDL and triglycerides. We make various forms. It has a function. It's useful. Our brain cells require it. We also know that as people age, that the people with the lowest cholesterol are the more likely to die. And the reason is not because low cholesterol, it's not because high cholesterol is healthy, it's because when your cholesterol goes down, it's a function that your body is decaying. We're not making enough cholesterol. And that is a dangerous thing. When we see people's cholesterol go down, we get worried about it because the liver is not working. So cholesterol is something that we make usefully. So it's not a grand evil. If we didn't have cholesterol, we'd have problems. The second thing we know is the amount of cholesterol that clogs up your arteries has nothing to do with cholesterol that you eat. That's pretty well known. First of all, we know that the cholesterol is tagged. They've done studies where they tag the cholesterol you eat, and they follow people down the road, and when they look at plaque in the arteries, none of that tag is in the arteries. What you eat, when you eat cholesterol, your liver makes less cholesterol. That's how it works. But the cholesterol that clogs up arteries is made by us, made by our liver. It's not what we eat. So we know eating eggs and shellfish is not bad for you. In fact, it's good for you. So that's a myth, though, that's tough to die. People still are afraid of eating eggs. We also know that some people are more likely to have their cholesterol stick to their blood vessels than others. And some people make a lot of cholesterol and none of it sticks, and some people make very little and a lot of it sticks. And we don't know why. And for the longest time, we've been trying to come up with markers, either blood tests or other tests, that would tell us if we are prone to have sticky cholesterol. Because yes, we can measure your cholesterol, but we can't measure whether it's going to stick. And there's some feature of this cholesterol that makes it sticky. And we don't know how to measure that. We've tried. People have heard of the cardiac-specific CRP, C-reactive protein. That was around for a while. Then we would start breaking down the cholesterol into LDL. LDL itself can be broken down into 10 different categories. And people thought, well, maybe some of those categories will tell. And if you have more smaller LDL than bigger LDL, a ratio, that people came up with these big formulas that looked good until they were studied a few times, and none of these have been proven to predict who's got bad cholesterol. So we kind of were left with, okay, if your LDL cholesterol is high, that's bad. LDL is the stuff that sticks. And if your HDL cholesterol is high, that's good. HDL seems to be a positive thing. When people have a lot of HDL cholesterol, that seems to clean it out from the blood vessels. But we're not sure about that now. There are some recent studies that even say that might not be true. There's no clean way to figure this out. And that's been the biggest problem, because we as doctors, you as patients, do not want all this vague uncertainty. You want to know that we can measure a number, fix the number, and you're going to be healthier because of it. That's what you want. And that's just not the case in this particular circumstance, or pretty much in any circumstance. But we like doing that. So when we find a high cholesterol, we treat it. So that's kind of the history of how we got to the cholesterol point. But what's the reality? What studies have been done? Well, so let's go back to attempts that have been made to lower people's cholesterol. So people with high cholesterol, one of the biggest studies was I'll give you two studies, the Framingham Heart Study and the Women's Longevity Study. Those are two studies that have looked at this issue. The Framingham Heart Study was really pointed to as clear indication that people with higher cholesterol were more likely to get heart attacks and strokes. But again, in recent analysis of that same data, that is not entirely the case. In fact, the measurement of cholesterol correlates very little, if not at all, to those who are going to get heart attacks and strokes. What they found is people with high cholesterol also were the least likely to exercise, were the more likely to eat poorly, were the more likely to smoke. They had a lot of other risk factors tied to the cholesterol. And when more recent studies peeled those away, it looked like the cholesterol itself had very little prognostic significance in terms of who was going to get a heart attack. So that was one study that, again, showed one thing and now shows something else. That's what you guys are used to hearing. You hear a certain truth, and then that truth is you're told it's wrong. That's the way of the world, because everything's uncertain. The second one, the women's health study, it showed something very significant, which was in women who had a low-fat diet, there was a higher risk of heart attack, stroke, and death. So that was pretty clear in that study. And that became big news, and people wondered why that was the case. And the reason people think it's the case is because, as we've talked about, there are good fats. And when people go on a low-fat diet and eliminate oils and nuts and other forms of good fat, they are actually hurting themselves. Secondly, people on a low-fat diet typically eat more sugar and carbohydrates. So they're actually having a lousy diet when they go on a low-fat diet. Now, of course, we're Americans, so when we see that result, then we next think, oh, we should eat a lot of fat. Because, we go from one extreme to the other. But, we all know moderation is really what's important. And people who went on a low-fat diet, especially back in the 80s and 90s, completely cut out fat. I mean, they started just eliminating all fat, and that proved to be very dangerous. And not a diet that anyone wants to be on. But again, it was fed by this myth. This myth that, yeah, it makes sense, less fat, because fat clogs up our blood vessels. Cholesterol clogs up our blood vessels. And some people who went on a low-fat diet had their cholesterol levels lower, and they still died quicker. So it wasn't as though measuring the cholesterol was an indicator that they were any healthier. So those are those are kind of the studies that have been done recently, looking at stuff that we kind of thought about a while ago. So yeah, cholesterol is there. Cholesterol sticks to blood vessels, right? Isn't that the big problem? Cholesterol creates plaque in blood vessels. That plaque clogs up the blood vessel, and then you get a heart attack or stroke. And that's what we want to avoid. So a couple things. One is that the clogging, we've talked about this before, but the clogging up process does not occur slowly. I should say, if you're going to get a heart attack, it's not because a blood vessel slowly clogged up. It's because the blood vessel closed up instantaneously. And it's not a gradual process. You don't go from 10% clogged to 30% clogged to 70% clogged to 90% clogged and then clog up. It doesn't work that way. You can go from 20% clogged to clogged. Just as easily as you can go from 70% clogged to clogged. The way a heart attack occurs is you have cholesterol plaque on the blood vessel walls. That plaque ruptures. The body tries to repair it, and in the process clogs up your artery. So the rupture can occur just as easily if you got 20% blockage as if you have 70% blockage or 90% blockage. In fact, the vast majority of heart attacks occur when you have 20% or lower blockage. And those are blockages that are not picked up by EKG, stress tests, or anything else. So you could go out of a stress test and think you're the healthiest person in the world and then have a heart attack on the way out and wonder why. It's because you didn't pick up all this plaque. So it's the plaque we worry about. Cholesterol plaque in blood vessels cause the problem. So what causes cholesterol to form plaque? So I'll pose two questions. Number one is, are people with high cholesterol more likely to have plaque than people with low cholesterol? And number two, are people on a high-fat diet more likely to have plaque than people on a low-fat diet? What do you guys think? Are people with high cholesterol more likely to have plaque than people with low cholesterol?
No. Yes.
Yes, on the left.
No.
No on the right. Anything in between? The answer is no. The answer is no. That people with high cholesterol, people with low cholesterol can have a ton of plaque. People with high cholesterol can have very little plaque. And so measuring cholesterol just in the blood tells us very little about whether you're going to have plaque. So what does measuring cholesterol in the blood tell us? Of use?
I don't know.
Anyone?
No.
Yeah, it doesn't tell us anything. So it doesn't tell us anything that's going to tell us whether we're going to have a heart attack, whether we're going to block up. We know this also from recent studies that people who show up with a heart attack in a hospital, just as many of them have high cholesterol as low cholesterol. It's a complete straight line. There's no difference in numbers of people with high cholesterol or low cholesterol and people who show up with a heart attack. So that number, we keep trying to figure out which number to measure. Again, breaking down the cholesterol into different factors, but we've never done it. That number has no prognostic significance. It means, in other words, it doesn't tell us if we are at risk. It's not a risk factor for heart disease or strokes.
Is it a risk factor for anything else?
Is it a risk factor for anything else? No. It's and how often do people get this number measured? And this is the debate that's going on in England right now. The debate that's going on in England is, why are we measuring this number? And one group says, you know what? I don't buy that. It doesn't make sense. I forget which magazine takes which side. The other group says, we got no evidence. Why are we keep measuring this number? The other one says, well, if you're really high, maybe if you're really high. But again, we don't have that information. And all the studies on cholesterol that have been done in terms of treatment were done in people under the age of 75 anyway. So we don't have the information on anyone older than that at all.
Can you measure the stickiness of the, you said so.
Can you measure the stickiness?
Yeah.
But they haven't figured out how to do that yet. They keep trying to figure it out because that would be what we care about, the stickiness.
I got to have very high cholesterol. I wanted to hear no.
You wanted to hear no, that's good.
Previously, it seemed to me at least, that there were a lot of, particularly men, having heart attacks in their 40s and 50s, and now they're not getting them that early anymore. So what, if it's not the cholesterol, what is the factor, stents or what?
No, definitely not stents. Stents don't really prevent heart attacks either. There are still a lot of people younger getting heart attacks. The biggest cause of a heart attack in someone who's young is just sudden blockage of a blood vessel. A lot of it's genetic. A lot of people, before they have that heart attack, have completely clean arteries. And they have some kind of damage that occurs to the artery, and that causes the body to try to repair it, and then they get a heart attack. Some of them have a single blocked artery, like one artery that's got a very unstable piece of cholesterol in it that got stuck. So it's real. The younger heart attacks are a very different entity because they don't tend to have a lot of plaque. They just have sudden heart attacks, and they die because a lot of them get that heart attack. They have what we call collateral circulation. Does anyone know what collateral circulation is?
Yeah, if something is blocked, the body finds another way.
Right. If something's blocked, the body finds a way to bypass the blockage. Most of the people in this room, I might be too, have blockages and have collateral circulation. So think about it. If you have collateral circulation, after years of blockages, and you block off an artery, you have a chance of still getting blood to your heart. But if you're 40 years old and you have no collateral circulation at all, and you block off an artery and it's a big artery, you're gone. And so people have sudden death. When the main presentation of a young heart attack is sudden death.
So if you have collateral circulation, comes with age?
It comes with blockages. Yeah.
I mean,
yeah. And usually with age. Yeah. It's a good thing.
Yeah, that's nice. I'm glad. Something's good.
Tell me what having a triple or a quadruple bypass does for you.
Yeah, bypass.
Well, we'll talk a lot about coronary disease. I don't want to spend too much time on that now because we have a whole talk on it. But when you open up a blockage, there's very little evidence that prevents heart attacks down the road because most heart attacks occur in areas without blockage. 85% of heart attacks occur in areas without blockage. But if you're having chest pain or congestive heart failure because you have low blood flow from your heart, then if you have a bypass or a stent and you open that up, then you're less likely to have chest pain or congestive heart failure. It helps your heart function better. So if you're having problems with a weak heart or you're having chest pain, a bypass or a stent will help that. If you're just doing it because you have no symptoms at all and someone just happened to find it, then there's no evidence that that's helpful in terms of preventing a heart attack. But there are things that are helpful, but that's not one of them.
Is there anything that can be done to increase the amount of collaterals that are developed in the heart?
Yeah, people are working on studies to try to increase the amount of collaterals. They're trying to use these growth factors. And this is being studied now to see if you can encourage blood vessels to bypass things as they block. The problem is your body's not going to bypass something until it's blocked over a certain percentage that we think is about 50 or 60%. So if you're walking around with these 20% blockages that you don't know about because you're having no pain, that if you get a stress test, your doctor doesn't know about because you'll pass your stress test, your body's not going to bypass those. And then you're prone to a heart attack. If you have a bunch of 20% blockages, you're a walking time bomb and you don't know it.
Statins are obviously the medication that's used to decrease cholesterol. Is there any other benefit to taking statins?
Well, you're jumping way ahead. Woo. Yes, we'll talk about statins. Well, let's talk about something else first. Before statins, when I think about my little 25-year career as a doctor, there have been a few drugs that have actually made a difference in people's lives. Not many, but statins are one of them. Statins are tremendous drugs that have actually saved hundreds of thousands of people's lives, without a doubt. So we'll talk about statins. Statins, should they be in the water? I don't think so. But there are people who definitely benefit from them. Before statins, we had other drugs to lower cholesterol. And at the time, because studies are what they are, people took these drugs and were led to believe that they were going to help them do things other than lower cholesterol. What are you taking a cholesterol drug for? There are two things. People feel very good, doctor and patient alike. Studies have shown this, when their cholesterol goes down a lot. There's a placebo effect, certainly, to that. People really like it. They're proud of it. They brag about it at dinner. It's a big deal when you lower your cholesterol. So that's one thing people really wanted. If I gave you a cholesterol drug and said, this is really helping you, but your cholesterol is actually going to go up on it, you're not going to be happy with this drug. And there are drugs like that. Number two, I think there was an underlying expectation that if you lowered your cholesterol, your risk of a heart attack and stroke was also going to decrease. And you wouldn't be taking it probably if that weren't the case. I'm not sure. I have patients who know their drug doesn't lower their risk of heart attack and stroke, but still want to be on that drug because it lowers their number, and they feel really good about that. So before statins, there were a ton of drugs that did just that. You could almost name them. Questran was one. What do we use Questran now for?
I don't know.
For chronic diarrhea. Because it constipates the heck out of you. That's what we use it for. It bloats you and constipates you. There is gemfibrozil, which we use now for triglycerides, but it turns out not to be a great drug for other things. There's niacin. There's one called Zetia, which we still use. Zetia is great. It lowers your cholesterol dramatically, and it changes your risk of heart attack 0. But people love this drug, and if they can't tolerate statins, they go on Zetia and they feel really good. But there have been 3 studies on it, and one showed that out of 1,000 people who take it, one person had a drop in their heart attack rate, and that was good because the other 2 studies showed no. So they've held on to this one study, which was done by the drug industry and really used the right population to do it. They keep doing it, so by chance, eventually they'll hit that one person. But we know that drug doesn't work. So why don't these drugs work? These drugs lower your cholesterol, but do not affect at all the stickiness of your cholesterol. They don't change that one bit. So you'll have less cholesterol floating around, but the same amount of cholesterol sticks to your blood vessels. So it looks like you're doing a great job because we lowered your serum, your blood cholesterol, but we have no way of measuring whether we lowered your blood vessel cholesterol, which is what we care about, the stuff that sticks and causes plaques. We now know from studies that every one of those drugs that I mentioned and many more actually do not lower heart attack or stroke risk at all, and some of them were found to increase the heart attack and stroke risk. And those are kind of just buried. We don't see those drugs anymore. But at one time they were touted as being the great drug. So then we came up with statins. Statins lower cholesterol, right? What else do statins do?
Give you muscle pains.
They give you muscle pains. They give you tiredness. How many people get muscle pains on statin? Well, this guy, David Nissen, wrote that nobody actually gets muscle pain, that it's It's an illusion from the internet that people are reading, and that it's false. And they've done some studies where they've created them very nicely so nobody gets muscle pains. We do have studies that show that people who are active, very active people, about 40% of people have either muscle pain or weakness. And people who are super active, like marathoners, 80% of them get muscle pain or weakness when they're on statins. People who are sedentary, it's about a quarter of the people, 25%. And sometimes it's not muscle pain, sometimes it's muscle weakness. So the amount of falls increases in people who are on statins. For some people, we don't know who. There's no way to measure that. And we also have studies that show about 40% of people on statins have perceivable increase in tiredness. So if we're gonna give a medicine, we should be honest about what the side effects could be. Are there more serious side effects than those two things? Serious meaning organ damage, anything like that? Not really. I mean, statins are pretty safe. We always talked about liver function. So everyone who was on a statin used to get their liver function test measured all the time. And we now know that's just not necessary. We don't do it anymore. It didn't correlate to anything. There's a very tiny percentage of people on statins who develop liver failure. But those were not people who had abnormal liver function tests. They turned out to be not related at all. And in fact, a lot of people on statins do have abnormal liver function tests, and that's perfectly normal and acceptable. Doesn't mean they're gonna have trouble. You could double or triple your liver function numbers, you'll be just fine. So the recommendation is not even to measure it anymore. Again, statins lower cholesterol. Is that good, bad, or indifferent? We know other things lower cholesterol. Why is statins lowering cholesterol different than other things lowering cholesterol? Any idea? The answer is, from what most people would tell you, is that their cholesterol lowering ability is irrelevant to what they actually accomplish. And we know that for a few reasons. Number one, people with very low cholesterols who have had a heart attack, who now go on a statin, the chance of getting another heart attack is lower than had they not gone on a statin. Okay. So people with high cholesterol who go on a statin, who don't have a risk of a heart attack, their risk of a subsequent heart attack is not changed from being on a statin. So we know that the amount of cholesterol you have and how much it lowers the cholesterol seems to be not that significant. What is significant with statins, where statins work, is not to give it to people with high cholesterol. It's to give it to people with high risk for having heart disease or having stroke, regardless of their cholesterol. People with a low cholesterol who have a high risk of a stroke or heart attack benefit from statins. People with high cholesterol but a low risk of stroke and heart attack do not benefit from statins. And the American College of Cardiology a couple years ago came out with this statement and said, this is what we should be doing. Statins should be given to people with a high risk of heart disease, not people with a high cholesterol. And a huge part of the cardiology community was just furious about this. Again, same debate that's going on in England is kind of coming here, except here, I hate to say it, but the cholesterol drug manufacturing lobby is powerful. They control a lot of what's said out there, and they control every study done on cholesterol is sponsored by them. And so it's harder in this country to get anyone to believe this reality that statins work regardless of cholesterol. Why? What do they do? What's the magic of statins? Let's say they didn't lower your cholesterol at all, they still would work. So what do? Well, what puts people at high risk of having a heart attack?
Blood pressure.
Not cholesterol.
Blood
cholesterol is not a risk factor.
Blood pressure.
High poorly controlled blood pressure. Now, if you have high blood pressure and we got you on medicines and we control your blood pressure, then you're fine. I have something that's really high risk, actually, that I'm not proud of, which is poor sleep. So somehow, people who have poor sleep are at higher risk. There's some recent studies that show that somehow they have more stress on their blood vessels when they have poor sleep. Anything that puts stress in your blood vessels. So high blood pressure that's not controlled puts a lot of pressure in your blood vessels and damages the blood vessels. And cholesterol tends to stick to damage blood vessels.
What is poor sleep? Dreaming or not sleeping at all?
Not sleeping too much. Those of us who get 4 or 5 hours a night, that's poor sleep. What smoking, tobacco, puts huge stress on your blood vessels, destroys blood vessels. And when you get damaged blood vessels again, cholesterol sticks. These blood vessels become very sticky, and cholesterol sticks to these damaged blood vessels. Diabetes causes damage to blood vessels. Mostly because people with diabetes, especially what we call type 2 diabetics, people who get diabetes as an adult, produce a lot of insulin. Their insulin does not work well, so they keep making more and more and more insulin. And insulin itself damages blood vessels. It's a major damage to blood vessels. So people with diabetes, even people who have diabetes under good control, are at high risk for having heart disease because they make so much insulin. People who have a bad diet, people who are obese, and people who eat poorly are at higher risk. What is eating poorly? Well, we've talked about that. Eating poorly is not eating, eating fat is not eating poorly. Eating poorly is eating a lot of sugar and carbohydrates. That's what eating poorly is. Eating a lot of sugar and carbohydrates increases insulin levels, increases damage to blood vessels. And obesity itself causes a huge increase in insulin. You make people who are overweight have a lot of insulin floating around their body. And insulin is just one of many things that cause inflammation and damage in our body. We talk about things that are inflammatory. A body that's inflammatory is more likely to have cholesterol stick to its blood vessels. And being overweight, eating poorly, smoking, and the last factor, not exercising. All those people who don't exercise have high inflammation in their body. And they're more likely to have cholesterol stick to their body. So a couple stories recently. I think I mentioned I wrote an op-ed against Nissen and it didn't get published. But I told the story of it was one person, but there were a couple people like this whose cholesterol was just really high. LDL, I don't know if you guys know what cholesterols are, but LDL over 200. Like people would faint when they had one of them saw a cardiologist who she did not want to take statins. She had a thing about taking statins. So we did a test that looked at whether she had plaque in her arteries, and she had none, zero plaque in her arteries. Why is that? Because she exercised, she was on a great diet, her blood pressure was controlled, she didn't have diabetes, she had a good family history, she had nothing that would cause her cholesterol to stick. And again, I've seen people with normal and low cholesterols who get heart attack after heart attack because they're sticky. Now, how do you measure whether you have plaque in your heart? Anyone have any idea?
There's some kind of...
We do have a test now.
Yeah, there's a test. I think
It's not a perfect test. At least it's better than some of the other things we had. It's called a calcium score. So a calcium score costs about $50. You get it at the local radiology place, wherever that might be. And they do a one-shot CAT scan, and they can see how much plaque you got in your arteries. And they measure it from 0 to about 3,000. So the two people I saw in 1 week a few months ago, both had zeros, who had LDL cholesterols over 200. They both had zeros. So zero means no plaque.
What would be an appropriate time to have that test?
11:30.
No.
Well, the people I send this test for are either people who have high cholesterol and are really nervous about it, but don't have a lot of the risk factors, or people who have some risk factors and do not want to take statins. And so we say, okay, let's check. So if I tell you, look at you, you have diabetes, you're overweight, you don't exercise, you're at high risk, let's put you on a statin. And you say to me, yeah, but my cholesterol's normal. I'll say, well, let's get a calcium score and we'll see where you are. Because again, I don't care if your cholesterol's normal. If you have risk factors for heart disease, then you will benefit from a statin, regardless of your cholesterol. So, but most people still have in their head, it's all about the cholesterol, so I get this $50 test.
So,
The great thing about this test is, unlike a stress test that will miss all these 20 and 30 and 40% plaques, this one shows all your plaque. So I have people who have 3,000, you know, that number. And I have a lot of people who have, you know, 5, 6, 7, 800. And we know from studies done on people with calcium score that if you have a low calcium score and your risk of a heart attack in the next year is less than 1 in 1,000. And if you add a statin to that, your risk of a heart attack in the next year is exactly the same. So we know if you have a low calcium score, adding a statin doesn't help. And the American College of Cardiology smartly talked about several studies that show that about 50% of people currently on statins do not need to be on them because they have a low calcium score. So they're on them for all the wrong reasons. They're on them because they have high cholesterol.
You haven't said anything about family history.
Yeah, and I should. Family history is a risk factor. Family history is a risk factor for heart disease. And I have a lot of patients with family history that I get these calcium scores on.
What about stroke?
Yeah, it's risk factor for both. And again, it's a risk factor enough. If you have a strong family history, I put everyone on a statin who has a strong family history. To me, that's a risk factor. And we don't know if that works. We have no idea if that works. It's not been well studied. But I figure, what the heck? You know, that's all we got. We got statins.
well, what are the downsides of statins?
Well, let's talk about more of the other stuff.
Okay.
So that's the real question.
Why shouldn't that calcium test be a routine blood test for everybody?
Yeah.
Why shouldn't it be a routine test? It's a good test, but if you have low risk factors or no risk factors, it could be a confusing test. It's not a perfect test. Most tests are accurate if you actually have what we call a high pre-test probability of having disease. So a certain number of calcium scores that are high are what we call false positives. They show that you have a problem and you really don't. The more you have risk factors, the more likely that you're going to have a problem. I do a lot of calcium scores because I do think it's a very useful test if you're at zero, if you're low. If you're low, it really tells you you're probably okay. Don't worry about it. Whatever you're doing, keep doing. And I'll do them every few years. I do think it's a good test. Why isn't it done more routinely? I mean, you want the cynical answer or you want the non-cynical? I mean, cynical answer is a cheap test that doesn't enrich anyone. So that's my cynical answer. There are a lot of people who are a lot of parts of our community, our medical community, that are opposed to that test. They say the studies aren't out there yet. Well, the studies on the calcium score are really good in terms of low. They're not as good in terms of high. So we know, when I give you a calcium score, I say we're looking to see if you have a low number, in which case we don't have to worry too much. And that's been proven pretty definitively that that's effective. But I got a patient recently who had really 80 years old, active, bicycles 20 miles a day, and is on a statin. And I said, I don't know if you need to be on the statin. Let's get a calcium score, expecting it to be 0, and it was 2,500. And the guy freaked out. So he thought he was going to die tomorrow. So it was not a test that helped him at all. He said, what do I do now? I said, well, just stay on the statin. I said, you're good. We got you on the right medicine. But he went and got a stress test and a catheterization and all this stuff, all of which turned out to be normal. He just has a lot of plaque, and statin's good for him. But it had a negative psychological effect. He stopped bicycling for a month, which is the worst thing you could do. Thinking he was going to die. So again, these kind of tests do have a downside also. You know, I wish I never got that test on him. He's okay now. And he got all this. But I do think it's a good test. And I think if there's any question of whether to take a statin, it's good. Oh, yeah, how effective are statins? Let's say you're at the highest risk possible. You've had a heart attack or a stroke. You have diabetes, you're fat, you don't exercise, you're at high risk. How effective are statins? The question would be, and I always use the same thing, out of 1,000 people who take statins, who are at that terribly high risk, versus 1,000 people who don't take statins, in the next 5 years, how many people who take statins are going to prevent a major event? Major event means a heart attack, a stroke, or death. Out of 1,000 people in 5 years. How many people? About 40.
Oh, that's a lot.
About 40 out of 1,000 in the next 5 years will prevent a heart attack, stroke, or death, which is 4%. So I got patients who say, you mean 96% don't get any benefit? I'll take my chances. But I said, but the 4% benefit's pretty good.
Yeah.
I mean, you're preventing some bad stuff. That's a good drug. 4% is as good as we get from any drug. That's about the best effect I've seen in any drug. But there are a lot of people who cannot tolerate statins, who say, well, 4%, I'm not going to kill myself and not be able to walk because of 4% benefit. So I get that too. Again, I've had people go to doctors and be told, if you don't take a statin, you're getting a heart attack. So you better take it. Now that's just false, misleading hyperbole that should never be told to a patient. The truth that should be told to a patient is you're cutting your risk down by 4%. And it's up to you as a patient to sort that out in your own mind as to whether that's sufficient for you to want to take this drug. There's another whole bunch of people in the cardiology community that believe, well, that's not enough. It's not just a matter of going on statins, you gotta go on high dose statins. And you gotta get your LDL cholesterol down really low. This is part of the debate in Britain too. And there's some studies that show if you really push down low, you can change that 4%. But when you really look at what you're changing the 4% to, you're changing it to like 4.2% at best. You're not moving the dial very much. And people over this age of 75, you're not moving the dial at all. But in people who are younger, you will move the dial a little bit if you give it what's called intensive statin treatment. You'll go from about 4% to about 4.1, 4.2% benefit. It's not a lot of people. Just a couple out of 1,000 will benefit from that high dose. The problem with the high dose statin is that whatever side effects you get from statins will be worse with high dose. Now, younger people tend to tolerate it better. As you get older, you have a harder time tolerating the side effects. So the side effects are not life-threatening, whereas the problem you get if you don't take a statins is life-threatening. So you're not comparing apples to apples here. What would you rather have, muscle aches or a heart attack? Most people would take muscle aches. But if you're told, well, there's a 4% chance of a heart attack or 100% chance of muscle aches, which one do you want? 100% chance means I have them. I got the muscle aches. So do I want to live with these muscle aches, or do I want to, or do I and have a 4% reduction in my heart attack, or am I going to get rid of the muscle aches and accept that risk? That's up to you, right? That's up to you as a person. It's not up to me as a doctor to tell you what decision to make. It's only up to me as a doctor to give you accurate information.
I thought the muscle aches were the underlying cause of some illness, some kind of,
Good question. The muscle aches, the manifestation of a serious illness, which we call myopathy. Myopathy meaning muscle damage, muscle breakdown. And you can measure that too. People who take statins can get a very serious destruction of muscles called myopathy. And there's a blood test you could use to measure that, called the CPK. The vast majority of people who have muscle aches do not have that problem. They just have muscle aches. Their muscles hurt. What percentage of people on statins actually get muscle damage from the statins? 100%. And it damages everybody's muscles. But it doesn't damage it a lot. And only a very small percentage have substantial damage that's dangerous. Most people, like I said, have damage, but they don't notice it. And a fair percentage, about half the people, do have damage that's noticeable, either through pain or weakness. There are ways to mitigate that to some extent. Lower doses of statins, changing the type of statin, giving statins every other day, taking something like coenzyme Q10, which can help a little bit. Those in some people could help it. But again, if I put someone on a statin every other day, it's not quite as effective as every day, but it's pretty good. But I've had people, other doctors, say that this is terrible. But again, What? So I told you 50% of people who are on statins don't need them, based on calcium scores. What percentage of people who would benefit from statins are not on them?
Yeah.
50%.
Oh.
Same number. 50% of people who would actually benefit from statins do not take them. And when they actually looked at that, they said, well, the reason is that the doctors who prescribed the statins were uncompromising. You had to take a high dose, you had to take it every day, and people got muscle pain, and the doctor said, that's a myth, you know, that you read on the internet, and they stopped the statins. Whereas you can keep the compliance number higher if you're willing to compromise with the patient a little bit. Say, okay, let's try something lower dose. Let's take it every other day. Let's try taking something with it. You know, take it for a few weeks, then stop it for a few weeks. You know, there are a lot of ways we can do it, and still get you on a statin by compromise, because every body is different. I always think if your body is got all those muscle aches, it's telling you that dose is too high. You know, so get down to a dose that's tolerable. If you tolerate a high dose, great. But that's one of the reasons. So we have a big, so the insurance industry in this country, knowing well that high-risk people would benefit from statins, is really devoted to trying to get more of those people on statins, because it saves them money. If people don't have a heart attack, stroke, well, death is actually neutral for the insurance industry. But heart attacks and stroke are expensive for the insurance industry. So they want these people on statins. And I've been on a panel that's tried to help them determine what the causes of non-compliance, and this is what I came up with, is that doctors are not fully honest about the side effects. They poo-poo the side effects. They say they don't really exist, and they're not willing to compromise with dosing. So I think that's, you know, as a patient, you could say, yeah, I want to be on this medicine, but I'm hurting. And as a doctor, it's our job to work with you and to be honest with you. So yeah, that's a downside of these medicines, but I do think most people can get around that if we compromise and we get you on a right dose. Again, I want to emphasize that statins are unique. Statins do not have their effect by lowering cholesterol. The only reason to measure cholesterol on a statin is if you are of the belief that the lower you push the LDL cholesterol, the more effective the statin is going to be. There is a group of people who believe that, and there's some truth to that, but again, we're talking 1 or 2 people out of 1,000 that benefit from that line of thinking. In most my patients on statins, I don't measure cholesterol before or after, unless I'm told to by the patient, because the patient wants to know that their cholesterol is lower. It's important. So, and I do it a lot because, unfortunately. It's okay, but I'm just saying that's not why so how do statins work? Anyone know?
No, that's a good question.
Something in the liver causes some fats and
They definitely work in the liver to help prevent cholesterol from being made. That tends not to be the real effective part of why they stop heart attacks and strokes, because other drugs do that too. They actually are strongly anti-inflammatory. They're powerful anti-inflammatory medicines that tend to be anti-inflammatory right in what we call the endothelium of the heart blood vessels. They are strong anti-inflammatories in the blood vessels in the heart. They go right there. And what a lot of people don't realize is, so in one way they prevent cholesterol from sticking. So if you have, let's say, a calcium score of 200, which is modestly high, but high enough that you're at risk, and you go on a statin and you check your calcium score in 3 years, it will never be better than that 200. Statins will never get rid of that plaque. That plaque is there to stay. So a lot of people get upset about that, but it shouldn't be much higher. You shouldn't be putting down new plaque. So that's one way it works. But the more important way it works is that plaque has to rupture for you to have a heart attack, and statins stabilize the plaque so it's much less likely to rupture. That's the main way it works. So you could have a plaque like that person I told you about that's 2,500, and he's on a statin and it's not rupturing. And by the way, That guy with 2,500 plaque that had plaque in every blood vessel, in every inch of every blood vessel in his body, had a normal stress test. Just to know how great stress tests are. Stress tests with nuclear imaging. 0, normal. Just to know how great stress tests are to picking up who's at risk for heart disease. The calcium score showed this guy is at high risk, and he was on the right medicine. He was on an aspirin and a statin. And that's all you have to be on. I told you before that stents don't prevent heart attacks. The reason is because of this. You could open up a narrowing, but you got all this other junk all over the place that can rupture at any time. So the way to prevent a heart attack is to go on the statin and the aspirin. So people who get a stent, who are on statin and aspirin, versus people who don't get a statin and aspirin have the same heart attack risk. It doesn't change. Being on the statin and aspirin is what prevents the heart attack in 4% of people, which again is a lot.
So if you take statins, you should also take an aspirin, or should you take aspirins?
Aspirin is an additional benefit. So
even if you're not on a statin?
Even if you're not on a statin, an aspirin will lower, if you're at high risk, again, an aspirin a day is not good for people who are not at high risk. It actually causes more problems than help. But if you have risk factors for heart disease or stroke, and interestingly, it's different in men and women. Aspirin tends to be effective in stroke prevention in women and heart attack prevention in men, and nobody understands why. But that's pretty consistent in the studies. But what aspirin, I told you the statin benefits about 4%. The aspirin benefits more like 0.5 to 1%, in addition to the statin. So if you take a statin and aspirin, you've increased your percentage by another 1%.
So the critical thing is you have to find out your calcium score first.
You don't have to find it out if you have high risk, but you could. If you're at high risk, let's say you had a heart attack in the past, forget it. Let's say you have blockages in your carotid arteries. You got blockages everywhere. Let's say you have peripheral vascular disease. You have blockage in your legs. You're at high risk. Diabetics, almost by definition, are at high risk. They benefit from statins by about that 4%. But if you're not sure, yeah, calcium test is a great way to see where you are. I think it's a great test to get, just to see where you are now in terms of plaque. Because if you have a 0 score, you could feel really good. That's what you should brag about. The best bragging is when you have a high cholesterol and 0 calcium. That's good material.
I want to ask a question back on blockage. What is left beta branch blockage? Is it serious?
Oh, left bundle branch block.
Right.
That's a whole different ballgame. That's has nothing to do with blockages of the artery. That's a blockage of your electrical system in your heart. And it's not that it's serious, it's just that it means that you can't interpret the EKG at all. It's hard to know what to make of the EKG. EKG becomes impossible to interpret. So if you're coming in for a heart attack with a hard chest pain and they do an EKG and you have a left bundle branch block, they have no idea what's going on. It's not in and of itself dangerous. But it's good to know if you have one.
So it doesn't help you to ever to get an EKG then, huh?
Well,
we'll find out about the rest of the problem.
We'll talk about EKGs down the road, but no, it doesn't. EKGs are a rough test.
You mentioned coenzyme Q10. What are the advantages and disadvantages in relation to taking statins?
Coenzyme Q10 has been not as well studied as it should be, but we know that our body makes this chemical called coenzyme Q10, and when you take statins, you turn off our production of coenzyme Q10. So we basically are not making any when we take statins. And a lot of people speculate that the coenzyme Q10 deficiency is what causes a lot of the muscle pain. That coenzyme Q10 is necessary for muscle function. And so when we stop that, then we're actually making the muscle pain worse. We also know though that statins have direct toxic damage to muscles. So coenzyme Q10 is not going to stop that. But it may help with that other part of the muscle pain. We also know people with congestive heart failure benefit from coenzyme Q10. So when we shut that off in people with congestive heart failure, that might be a problem. And maybe they should take it too. The downside of coenzyme Q10 is only that it costs a lot of money. It's not, there's no No one's ever shown a negative to it. Of course, you know, as with everything, we found this advantage of coenzyme Q10, so now everybody wants to take it for everything. But we don't see any evidence of taking coenzyme Q10 in people who are not on statins. That's never been proven. But on statins, it does help some people with muscle pain. And it may help congestive heart failure, we're not sure yet. The only study I saw in congestive heart failure had 20 people in the study. So not enough people to make a good conclusion. But it was really impressive, 19 out of the 20 benefited. But it's still only 20 people.
Benefit in relation to muscle pain?
No, congestive heart failure. Fewer hospitalizations, yeah, for congestive heart failure. So they say they're doing a bigger study on that. But again, the coenzyme Q10 market, in terms of sponsoring studies, is not big enough to suggest they're going to do this big multi-center study. So I don't see it coming. They don't have a lot of power to create studies. But it might be useful for people with statins. I don't think it's a bad idea to take it. And we don't know, there are other things too with statins that might help them to work better. But again, I started out by saying statins are one of the medicines in my lifetime that have made a big difference. If you think of high-risk people, 4% of them avoiding a major outcome in 5 years, that's pretty impressive. If you look at the whole country, how many people are helped by these medicines. But if you look at how they are overused, used to treat high cholesterol and not used to treat people with high risk. And how many people with high risk are not on statins because their cholesterol is normal. That shows you how dangerous it is sometimes to measure cholesterol. It's sending us the wrong direction. Because when we don't give someone a statin because their cholesterol is normal, but they're at high risk for heart disease, we are preventing them from getting a medicine that is of great value to them. So measuring cholesterol could actually cause us to hurt you by thinking you're okay. And it's not. Low cholesterol does not mean you're in any way okay. Normal cholesterol is not a bragging point. It's all these other risk factors we have to be concerned about. And of course, some of these risk factors you could take care of yourself. Diet and exercise, you can take care of yourself. If you figure out how to sleep more, I'd be interested in hearing about that. But you see, CPAP machine might work. But yeah, some of these you can take care of yourself, and some of them you can't. Family history, you can take care of yourself. You're born with a good or bad family history, and a lot of people who have diabetes, they can't do anything about it. You know, a lot of people who have plaque in their blood vessels, they can't do anything about it. So yeah, going back to the question of should everyone get a calcium score, I think a lot of people should. I think it's a good way to look at where you are. But you have to go into that test knowing it's not 100% accurate if it's high. You can't let it upset you if it's high. And that's hard to say to anybody, because it's going to upset you if it's high. But it's really good if it's low. So, whatever that means. Any questions? How are we doing? Are we good with time? Yeah, so we're done. But any questions about this? I bring it up because it's a controversial topic, but really it's not as unclear as people make it seem. I think we kind of understand a lot of this. What we don't, what the controversial parts are of this are whether measuring cholesterol is a good way to determine if statins are effective or not. That's still controversial. But whether cholesterol itself should be measured as a risk factor, I think we're way past that now. It's not a risk factor. And we shouldn't be so focused on that number or care about that number. I think we should be focused on other things. And that statins are not cholesterol medicines. We have to get away from thinking of them as cholesterol medicines. They're medicines to prevent heart attacks and strokes. They are not cholesterol medicines. So we got to think of them that way. And there are a lot of people in the cholesterol drug statin lobby want you to think of them as cholesterol medicines because they want everyone with high cholesterol to be on these medicines. And that's just overkill. That's why it shouldn't be in the water. Because the more we put it in the water, the more people are going to ache from this, and then the fewer people who actually benefit from these medicines will take them. So that we want to save our medicines for people who need them, not just give them to everyone.
What number is a good number to have cholesterol?
What's a good number to have cholesterol?
150 is at least average, isn't it?
Well, when I talked about the diet talk, I said, how many eggs are too many eggs after telling you that eggs are good for you? And some people still said 2 eggs, 3 eggs. And I said, but eggs are good for you. You can eat as many as you want. And what I'm saying here is, we don't care what your cholesterol is. There is no good number. You could have a cholesterol of 100, and your spouse could have a cholesterol of 200, and you who has 100 might be at higher risk of heart attack than your spouse of 200. So we don't want the cholesterol to let you believe that you're healthier or less healthy just based on the number. We don't know what a good number is. We just don't know. It's not a number that has much significance. What we'd like to know is how much of that number is sticking to your blood vessels. And when we figure that out, and a calcium score helps us with that. But there's no blood test that we know of that can help with that. We'd love to have them, but your risk factors make it more likely. They determined that you could figure out more about who's going to get a heart attack just from asking a few questions about risk factor than you can from doing any other test, stress test, catheterization, cholesterol, whatever. Those few questions are more indicative of who's going to get a heart attack than anything else you could do. And those are the diabetes, blood pressure, exercise, diet, family history. Those questions are more significant than anything else you could do. And they determine more than anything else who would benefit from a statin cholesterol medicine than anything else you can do. And this calcium score is now added to that list of something that helps.
If you have blood pressure which is under control, is that a risk factor?
No.
Okay.
But if you have diabetes under control, that's still a risk factor. Because you're still making insulin.
How about pre-diabetes?
Pre-diabetes.
Is there such a thing?
There's no such thing, but look, pre-diabetes is another name for what we call the metabolic syndrome. And metabolic syndrome are people who are making a lot of insulin. And so if you make a lot of insulin, you're at risk. You're at risk for heart disease. So but we don't, having a slightly high sugar doesn't mean you're pre-diabetic. We really want to figure out a way to measure how much insulin you make, and we don't know how to do that yet. So we don't know. That's why pre-diabetes is a made-up term. We're all pre-diabetic. But people who are overweight, who eat badly, who don't exercise, probably are pre-diabetic. And then you're probably making a lot of insulin. You might be making a lot of plaque. And those are the people that could get into trouble when they go to the doctor and have a normal cholesterol and think they're okay. That's a big piece of information that you've just received that makes you feel good. Or then you go to a doctor and get a stress test and that's okay. And then you feel like you're okay. Big, or an EKG. Those are not good, 85.
Why do they keep doing EKGs?
I don't know. I don't know. And I've worked with insurance companies who ask the same question. Why do we keep doing this?
EKGs, it doesn't show anything. You could have a heart attack.
On the way out, while you're getting your normal EKG, you can have your heart attack. It doesn't show anything. And I've said that, that 85 to 90% of people who get heart attacks would have had a normal stress test and EKG the day before the heart attack. So they don't show much. Why do we keep doing them?
It only shows if you're having a heart attack.
That's right. That's what it shows. If you're lucky enough to catch it at that moment, you're in good shape.
What's the point?
It's really not. You should not walk out from a normal stress test and EKG and say, I'm safe. And same thing with cholesterol. You should not have a normal cholesterol and say, okay, I'm good. It leads you to false security. You have to look at other risk factors that are more realistic. And be concerned about them. And if you're not sure, get a calcium score and see where you are. And if your calcium score is high, then a statin will benefit you by the 4% that I mentioned, which is good.
What are you going to talk about triglycerides? I think that's more important than cholesterol, isn't it?
Triglycerides are part of the cholesterol, and it seems to be very little significance, unless it's really high. Really high being over 600 to 800. So
don't you get strokes?
No, it turns out triglycerides are not that important. A little bit more important in women than men. Not important at all in men. A little bit more in women, but not much.
And it doesn't
So-
have anything to do with getting diabetes?
Well, people with diabetes have high triglycerides. So the reason you talk about pre-diabetes, people with high triglycerides are probably on the verge of getting diabetes if they don't have it already. Yeah, that is I had someone recently who came in whose triglycerides were 1,500, which are really dangerous because you can get pancreatitis from that. That's the main risk factor. And her sugar was up, new diabetic. When we treated her sugar, triglycerides went down to normal. So that it was a manifestation of this new diabetes. So yeah, triglycerides as an independent risk factor, no, they're not independently associated with heart attack or strokes. But they do show you might be pre-diabetic or have metabolic syndrome. Metabolic syndrome meaning you're making a lot of insulin. And so you're at risk for that. The triglycerides don't put you at risk, but what caused the triglycerides to go up might put you at risk.
You can get them down by letting up on your desserts, right?
You sure can.
Candy.
You sure can get them down by cutting down the carbohydrates,
I
yeah.
might as well move.
That's right. That's right.
don't have to
And
eat
you know
it.
what? That's a decision that you gotta make yourself. Because who knows what's more important. Okay, I'll see y'all next month.
Very good. Thank you.